Subarachnoid hemorrhage. One of the most common reasons for admission to the neurocritical care unit is to treat patients with subarachnoid hemorrhage. Here is a CAT scan of a typical patient with a fair amount of blood in the basal cisterns following an aneurysm rupture. Patients with subarachnoid hemorrhage have both classic and not so classic features upon presentation. The most common classic stereotypical presentation is that of a severe new onset headache, often described as the worst headache of one's life. There are scoring systems used to grade the clinical severity of subarachnoid hemorrhage. In fact, it is necessary when doing an admission, we document the Hutton-Hess score upon admission for these patients. As you can see, the higher the number, the worse the severity of the patient's condition upon presentation. Non-contrast head CT is the gold standard for diagnosing patients with an acute bleed from a subarachnoid hemorrhage. It is pretty sensitive, though there are situations which can lead to false negative CTs. When one is diagnosed with a subarachnoid hemorrhage, they must universally receive a CT angiogram of the head. It is important to bear in mind whether or not one has renal dysfunction, but we need to always weigh the risks and benefits in those circumstances when doing the test, as it certainly impacts one's treatment path. If imaging is negative, it may be necessary to perform a lumbar puncture to look for xanthochromia. Bear in mind, it takes several hours for this to develop, and if you do a lumbar puncture too soon, you may not see it materialize. Here's a table outlining typical findings when one has a subarachnoid hemorrhage on lumbar puncture. It is very important to avoid complications early on and throughout the treatment of patients with an aneurysmal rupture leading to subarachnoid hemorrhage. The first thing to bear in mind is controlling systolic blood pressure. The goal with a subarachnoid hemorrhage is to keep the systolic blood pressure less than 140 millimeters of mercury. We tend to favor short-acting titratable agents such as nicardipine or clofidipine. You must also reverse anticoagulopathy. And prior to the aneurysm being secured, we do employ seizure prophylaxis. Treat pain and anxiety, and use antiemetics as needed. It is not uncommon to see a decline in neurological status for patients presenting with subarachnoid hemorrhage. Again, based upon the timeline, it directs you towards the possible causes of such a decline. Before securing the aneurysm, re-rupture is a common cause of change in status. Acute hydrocephalus and seizure are also something to think about early on in the course of these patients. Hydrocephalus is caused by blockage of the CSF circulation and absorption within the ventricular system. When patients develop hydrocephalus, they can become obtunded or comatose, and in these situations, the neurosurgeon will place an EVD, or external ventricular drain. It is important to re-rupture the aneurysm as part of the initial subarachnoid hemorrhage management. Antifibrinolytic agents may be used in rare circumstances to reduce the risk of re-rupture. Be aware of the side effects of using these agents. It is rare to see them used at Maine Medical Center, as endovascular specialists are available to treat these patients in a rapid fashion. When an aneurysm is identified, there are two options to treat it. One is a surgical clipping versus an endovascular coiling. How one chooses which method to use is based upon the size, location, and anatomy of the aneurysm. And this will be determined by the neurosurgeons as in conjunction with the neurocritical care team to develop a treatment plan for each patient. As these patients recover from their subarachnoid hemorrhage, one of the untoward side effects or results of the injury is what's known as vasospasm. It's thought to occur in up to 30% of these patients. Starts at day 3, usually the risk peaks at day 7 to 8. Why does it occur? There are substances released from the lysis of blood which are spasmogenic. And the big danger is delayed cerebral ischemia leading to stroke. There is a difference between radiographic and clinical vasospasm, as it's not uncommon to see findings on a CT angiogram of a narrowing artery, but the patient may not be showing any neurological deficits at the bedside. The risk factors include the severity of bleeding, proximity to major vessels, age, a poor clinical grade, such as a higher number on the Hess scale, smokers, and the modified Fisher grade. The modified Fisher scale incorporates radiographic findings to generate a risk of vasospasm for our patient population. As you can see described here, the thicker the blood and whether it gets into the ventricles impacts the risk of vasospasm during the clinical course. This certainly helps us risk stratify and predict what may happen as a patient's recover in the neurocritical care unit. Is it preventable? One of the agents used is nimodipine, which actually is a level 1 recommendation based upon the evidence for use in subarachnoid hemorrhage patients. It is used every 4 hours for 21 days. It's shown to decrease the incidence of delayed cerebral ischemia, but does not necessarily prevent what we see on imaging in terms of radiographic vasospasm. Be wary of drops in blood pressure when using nimodipine, and it's sometimes necessary to change the prescription to 30 milligrams every 2 hours to avoid big swings in patients' blood pressure. Now, how is vasospasm diagnosed? Is a clinical diagnosis in which you will see changes in the patient's neurological exam. This may include focal deficits such as hemiparesis, speech problems, or may include more vague findings such as change in behavior. Once it's suspected clinically, then there is radiographic imaging done to better define the severity. How is it treated once it occurs? The first thing is to augment blood pressure, make sure the patients are euvolemic. If the patients don't show clinical improvement with these first 2 steps, it may be necessary to go to the interventional suite for administration of vasodilators locally to the narrowed artery. In rare circumstances, you may even see balloon angioplasty performed to avoid permanent fibrosis of the affected vessels. With subarachnoid hemorrhage, it's very important to avoid prognostication too early. We have all been humbled by patients presenting with a very high Hunt and Hess who end up walking out of the intensive care unit 2 weeks later. One must be very vigilant for any changes in their status, and if there's any uncertainty, please ask.